One thing that's really important when delivering the head is make sure that you have a little bit of more height than would be typical for an optimal height for operating. Like if we've had the table, if we've typically have an operating room table about at waist level, you're going to want a little bit of a height advantage. So if we haven't been operating on a step by then, we may choose to use one if we're not as tall as the other person across the table. Mm-hmm. So when the surgeon goes to deliver the head, the correct thing to do is cup your hand slightly, take your fingers and go straight inferiorly and deep into the pelvis. When you find the head in the pelvis, you may or may not be able to identify the exact position of the baby's head, but what you're hoping to do is have the palm of your hand just resting slightly against the vertex of the baby, right where the posterior fontanelle would be. And the reason you want that, and you may not be able to identify it perfectly, but what you're trying to do is elevate such that when you push up, the baby is going to flex its neck. If you are pushing straight up and you're getting the feeling that the baby is extending and trying to stargaze, that's a really hard position to get a head out of the pelvis. So again, take your hand and drop it deep and inferiorly using your fingers. And at this point, find with your palm the vertex if you can, and elevate the head such that you're creating some flexion at the neck, hopefully, and elevate straight up. What I notice residents will do sometimes, because they're having trouble getting the head to elevate, is they will try to use more of their forearm and they dig deeper. And that's actually a little counterproductive, and it creates a lot of extension on the hysterotomy site, and the extension will go down towards the cervix and the vagina. So if possible, again, take your hand right above the pubic bones, deep and inferior, with the palm of your hand, find that vertex, hoping to create some flexion at the neck, and elevate straight up. Try not to dig with your wrist and your forearm.
So you're trying to get the baby to elevate in the pelvis, not out of the hysterotomy.
Right.
Initially.
It's pushing superiorly, not necessarily up. Okay. When you first put your hand in, it is inferior and deep. And then if you can wiggle a little bit, but don't dig with your wrist or your forearm, because it is counterproductive. I should be clear that once the head is elevated, the person who is elevating the head should ask the assistant to apply pressure to the fundal area to deliver the baby. If the person who is elevating the head is also the primary surgeon, if you don't have anyone else, your non-dominant arm will actually be applying that pressure with your forearm or your hand, whatever creates the most pressure for you. At that point, once you are applying that pressure, then that head's going to come out of the pelvis at that time. And then the same motions you would use on a vaginal delivery, once the head is through the hysterotomy site, anterior shoulder, posterior shoulder, the remainder of the baby should follow with some gentle traction. Excellent. If you are operating with an assistant, typically the most useful thing for your non-dominant hand to be doing is to slightly retract at the hysterotomy site or the uterine wall. Typically that's going to be the most helpful with this hand. Again, if you don't have an assistant, your left hand or your non-dominant hand will be doing the actual pressure on the fundal aspect of the uterus. Mm-hmm. If the baby is breech, and it can depend on the breech presentation. So if we have a frank breech presentation, which is typically the most common presentation of a breech baby, the most important thing to do, again, with the delivering hand, deep and inferior with your fingers, find, in this case, the buttocks of the baby, the most inferior aspect of the buttocks of the baby, and elevate. Sometimes the baby will be positioned in a way that it's laying on its side, or even that the feet are towards the maternal abdominal wall. The easiest way to deliver a breech baby, the best way to do it, is once you've elevated, position the baby sacrum anterior. Get the sacrum lined up with the anterior abdominal wall. At this point, delivering the legs in a frank breech baby, you're going to take your thumb and put it right at the hip, at the flexion point in the hip, and your fingers at the popliteal fossa, and you are going to flex at the hip, and it's going to create a flexion at the knee, and then you're going to deliver one leg, and then the same thing on this side. Probably with my non-dominant hand, it's going to land with my index finger there at the flexion point of the hip, and then my thumb at the popliteal fossa. Bring that up. That reduces the legs, and you're going to deliver baby to the hip and then to the scapula. Usually your assistant is going to be helping you. The arms are not always cooperative either. Sometimes you can have an arm that's actually located behind the baby's head. Sometimes it's straight up. But the delivering physician's hands will be thumbs on the scapula. Reach up with your fingers and reduce the arm. That's why if we have what we call a nuchal arm, my fingers are going to gently take the arm and sweep it here. It sweeps around the baby's abdomen to here. And then the same thing on this side. This hand is going to reach up, find that arm, sweep it down by the abdomen to here, and we are right at the level of the neck. We don't want to pause here. We don't want the baby to get the cervix retracted around the neck if possible. We want to be rather quick at the hysterotomy site, and we're going to take our fingers immediately to the baby's face, to the zygomatic process on each side. Again, your assistant is going to be helping you negotiate the body of the baby, and you provide flexion at the cheeks. And sometimes the assistant will even put a little pressure on the fundal aspect of the uterus to get the head out. And then the head's going to come out. And then usually you just flip the baby this way and suction the mouth and nose.
And the big thing is not to put your finger in the baby's mouth, like you would never, because you can disarticulate
the mandible.
The mandible.
Yeah. Sometimes it'll fall there, but again, don't use it as your pressure point or your pivot point. Sometimes, again, if the baby starts to stargaze, this can be a really hard position to deliver a breech baby. You will try to reduce that, just like you did the arm. Just try to reduce it. If it's not happening, you can actually swivel the baby such that you would reposition it this way, and sometimes you can get it. If the head doesn't deliver at that point, you would tee the uterus with a bandage scissors. Usually about 2% of babies are breech at term, and a higher number at more premature gestations. But in general, there's not a lot of breech deliveries that you're going to do. So you really have to just be prepared for those maneuvers. Although frank breech was the most common presentation, footling breech, double footling breech, or complete breech also will present. And the maneuvers are basically the same. So if we have a complete breech, where the baby is sitting cross-legged, again, elevate, and all you do is do the exact same maneuvers that we did. Position sacrum anterior, find the flexion point at that hip, thumb in that flexion point, hand or index finger at the popliteal fossa, create a bend, sweep it out there. And the same thing on this side. My index finger is in the flexion point of the hip, my thumb is at the popliteal fossa. It's creating that bend, and then the baby's legs. The same maneuvers to deliver the rest of the baby. If you have a footling breech and you're not even sure what leg you have, let's say someone comes in, they're preterm, the water is broken, and you have a foot down low, that can be a very difficult position to get a baby out. Again, find the most inferior aspect of the baby. If there is a foot that is descending inferiorly into the vagina, again, try to find that flexion point of the hip, create that flexion at the hip. It should bring that leg up, and you can deliver that one, and then you'll find the other one. The exact same maneuvers that you use on your C-section are the same maneuvers you'd use vaginally. Most of the ones we do on patients that are coming in that are complete and going quickly, those maneuvers are going to work really well. On the rare situation where the baby is going to require more than one contraction to deliver the baby. The hardest part is waiting for the next contraction when you're at the hips or the scapula. You really should not pull on the breech baby if there isn't a contraction present and the baby is taking more than one contraction to deliver. Now, if the only aspect of the baby that has yet to deliver is the head, that is a much more dangerous situation with the breech delivery, and you'd be doing some other maneuvers if the head was stuck after a contraction. But again, in most cases where you would be delivering a breech baby, that in someone who simply had the urge to push and could not wait, you would follow those same maneuvers that we showed you for the C-section delivery.